So I'm going to be teaching you about granulomatous diseases today. And let's first talk about the granulomatous inflammatory diseases, and then we'll proceed to granulomatous neoplasms. In granulomatous inflammatory diseases, so we have largely covered the papillosquamous and blistering diseases. So we have graduated from the epidermis to largely now being a dermal process. So most of these entities that you see present with papillonodular lesions, but without much epidermal change, as it would be obvious. So a granuloma, what is a granuloma? A granuloma, we know, is a delayed hypersensitivity reaction that occurs with the collection of epithelioid histiocytes. So the process is in the dermis, and the histiocytic cells and giant cells are an important component of a granuloma. Now, based upon how the granuloma looks, it's classified as sarcoidal, tuberculoid, palisaded, and suppurated granuloma. So based upon how it looks and plus what is the composition of the granuloma, that's how it's classified. So when we call something a sarcoidal granuloma, we largely refer to it being a naked granuloma. What does that mean? It means that it's largely a collection of epithelioid histiocytes, but it does not mean that it will not have lymphocytes within it. There are absolutely a sprinkle of lymphocytes within the lesion and especially surrounding the lesion, and that's completely fine. However, there is nothing inside the granuloma and outside the granuloma. So if I form like a nodular fist around the granuloma, it's like a pink fluffy ball. I can nicely form a circle around it. So when I see that nice, tight, round nodular aggregate of epithelioid histiocytes, as I'm seeing over here, that's a sarcoidal granuloma. Giant cells are an important composition of sarcoidal granulomatous reaction, especially prominent in sarcoidosis or a sarcoidal granulomatous reaction. So that should not deter you from diagnosing that entity. The other thing is that when we talk about a sarcoidal granulomatous dermatitis, a prototypic disease that does that is sarcoidosis. And the classic lesion of sarcoidosis, the granulomatous reaction involves the dermis, upper and the mid dermis, very often present in a lichenoid distribution, but not really destroying the epidermis. So we'll see what that really means. However, there are variants of sarcoidosis which can present just in the fat or subcutaneous sarcoidosis, and I'll show you a slide of that. But this is the classic location in the upper and mid dermis. Now, a sarcoidal granulomatous reaction can obviously be incited by a foreign body, so we'll talk about that as well. So this is pure sarcoidosis where you see the nice round tight sarcoidal granulomas. So let's see another example of sarcoidosis. So here you have, this is what I was referring to. This is a nice example of sarcoidosis where the sarcoidal granulomas are present in a lichenoid distribution. So they are in the upper dermis in a lichenoid distribution, but not destroying the epidermis. And you see this nice round nodular aggregate. There is a mitosis within a histiocyte over here, which is completely fine. So you can see that there is a good lymphocytic infiltrate, but that doesn't prevent you from making the diagnosis of sarcoidosis. This is still a sarcoidal and not a tuberculoid granuloma, because I can see the nice round aggregate of the cells in this lesion. But this is sarcoidosis. This is a classic looking. Yes.
On that previous example, the first granuloma you showed, if I saw that, I wouldn't call it naked because it has all of the lymphocytes around it. So I'm wondering.
So that's exactly what I said. Lymphocytes are not a determining factor in whether it's naked or not.
Oh, perfect. Thank you.
In every sarcoidal granuloma, you will see lymphocytes within it. So there is no granuloma which doesn't have any lymphocytes in it. By a naked granuloma, you largely refer to as comparing it to, say, palisaded granuloma. Like there is nothing inside it and there is nothing outside it. And lymphocyte should never be preventing you from diagnosing a sarcoidal granuloma. If you can find, it's a puffy ball, if you can find like a nice circle around it, you can say that, okay, I'm closing my fist and this looks round and nodular aggregate, that's good for sarcoidosis. Okay?
Gotcha.
So the subcutaneous sarcoidosis is very rare, and I highly doubt you'll get a slide of it. It can present as a paniculitis, and here you get nice round sarcoidal granulomas in the fat. That is referred to as the Dario-Roussey variant of the disease. It's very uncommon. I've seen only a couple cases of it. Most commonly, you will get sarcoidosis in the upper and the mid dermis. An important board question, obviously, is sarcoidal granulomatous dermatitis by a foreign body. So this typically produces back-to-back packed sarcoidal granuloma. So you can see the sarcoidal granulomas, they are packed back-to-back. They're facing the entire dermal architecture. And on low power, you can obviously see some holes and spaces in the tissue. When you go up on those holes and spaces, you'll see these fragments of polarizable foreign body, which obviously you cannot polarize it under the when you're looking at it on the screen, but you should be able to say that that's fine. This is a nice sarcoidal granuloma because you're seeing these holes and spaces in the tissue with these kind of refractile stuff stuck within it, as you can see over here. So that is because of a polarizable foreign body like silica. Non-polarizable foreign bodies like beryllium and zirconium can also produce a good amount of sarcoidal granulomatous dermatitis, which can look indistinguishable from sarcoidosis. And when that happens, you cannot see any foreign body with the naked eye. You will have to have a high degree of suspicion, and further tissue analysis studies would need to be done. So that's classic for beryllium and zirconium. On the other hand, sarcoidal granulomatous dermatitis, we know, can be incited by by tattoo pigment. So you can have sarcoidal granulomas arising in the background of tattoo pigment, and the most common sarcoidal reaction pattern is produced by tattoos containing cinnabar or red mercury tattoo pigment. But any other tattoo pigment can basically do that. And so you can see here that there is background nice tattoo pigment, and you have this nice nodular aggregates, these sarcoidal granulomas arising in the background. Now, whether this is sarcoidal granulomatous reaction because of the tattoo or this is true sarcoidosis arising within the tattoo, we don't know. We can just call it a sarcoidal granulomatous dermatitis secondary to tattoo. But most of these patients who form this sarcoidal response to tattoo have a sarcoidal diathesis. So it's not uncommon that they go ahead and they develop true sarcoidosis. So you cannot really distinguish. It looks indistinguishable from sarcoidosis if you take out the tattoo pigment. Okay, so that was about your sarcoidal granulomatous dermatitis. Now let's come to your next granuloma, which is going to be a tuberculoid granuloma. So this is answering your question. If you see here, this in contrast to a sarcoidal granuloma, they literally look like bag of worms. And on low power, you can appreciate a vague nodularity. But when you go up on high power, you have problems drawing a circle around this lesion because it's not very well defined. That is what a tuberculoid granuloma is. It's blue and pink nodular aggregates, which are not very well defined. And they have classic appearance. They look bulbous, swollen, and they're often oriented perpendicular to the epidermis. Now, when I'm referring to a tuberculoid granuloma in this scenario, I'm taking out neutrophils from it. If you see neutrophils in a tuberculoid granuloma, that becomes a suppurated granuloma. So that is important because if you are classifying something as a suppurated granuloma, which is a tuberculoid granuloma with neutrophils, which is even less well-defined than a tuberculoid granuloma, then you are worrying about a whole different degree of infections, which we are going to be talking about soon. But when we are talking about a pure tuberculoid granuloma, I'm referring to still a nodularity of the lesion. There's kind of like a vague nodularity with these balls oriented perpendicular to the epidermis, appearing to grow like bags of worms along the neurovascular axis. When I see this without the neutrophils, the two diseases that I think about are also infectious, but they're very different from the other infections we're going to talk about. It's tuberculoid leprosy and syphilis. So in tuberculoid leprosy, classically, this is from a patient with tuberculoid leprosy, you will see perineural inflammation. You do not see in this particular slide, but that can be a good clue. Tuberculoid leprosy, the body has extremely good immunity. So you are basically not going to be seeing the bacteria easily, the Mycobacterium leprae. You will have to do multiple levels of stains with fight to be able to see maybe if you get lucky one organism. Most often, we will have to do PCR analysis on the tissue to be able to detect that bacteria. So this is tuberculoid leprosy. Now, when you see, let's go to the example of syphilis. Now, when I see same thing, you see these nice round nodular aggregates. They are blue and pink. They are oriented perpendicular to the epidermis. And when I go up on high power, that crispness of the pink ball is lost. That's what I mean by tuberculoid granuloma. If you look at the composition of this tuberculoid granuloma, this one has like a lot of plasma cells within the lesion. So you can see all these plasma cells with eccentric nuclei. So tuberculoid granuloma with plasma cells is when you think about secondary syphilis. So tubercular granuloma with plasma cells equal to secondary syphilis. In real life, we are going to be doing special stains like the Treponema pallidum antigen immunostain. This particular stain does not correspond to that particular slide, but I just wanted to show you the stain. And we will, it's a stain that works pretty well in contrast to, say, using Giemsa stain, which has very high background staining. It's an immunostain which will attack the spirochete organisms. And you can see that the spirochetes are being highlighted using the red chromogen in my laboratory. We often, this may not always be red. You can use any color. The next most common color to use is a brown stain, which has a high background staining. So we tend to use the red stain, which stains better. So this is the spirochete organisms highlighted using the Treponema pallidum antigen immunostain. So that's secondary syphilis. So that's a tuberculoid granuloma. On the other hand, what is now a suppurative granuloma? So suppurative granuloma, as the name suggests, has suppuration, which means neutrophils, and has the granuloma, which is a tuberculoid granuloma. So tuberculoid, what is a tuberculoid granuloma? It's a collection of histocytes with lymphocytes. So suppurative granuloma looks really, really busy. So when you see it, now, unlike sarcoidosis or tuberculoid granulomas, it typically doesn't have any architecture. It will efface the dermal architecture, and you will get this diffuse infiltrate. And when you go up on high power, you will see that they are easily neutrophils, lots of neutrophils. There is some background subtle necrosis, though this is not very obvious. The necrosis is not very obvious. And you also see these lymphocytes and these pink areas, which are your histocytes. So you will also see giant cells within the lesion. So that's a suppurative granuloma, which means it has neutrophils and it has granulomatous inflammation. The epidermis can do variable things. The epidermis can be ulcerated. It can be hyperplastic. It can be unaffected. So it can do varying things. Like, for example, in this suppurative granuloma, this was a dermal nodule. And what I see here is a large granuloma, which is necrotic in the center. So you can see that it has got nice necrosis in the center. There are giant cells within the lesion. And you can see neutrophils in the background. The other thing, the suppurative granuloma, when you look at it at low power, sometimes it can give you a pseudo-palisaded look. The necrosis in the center can make you think that this is a palisaded granuloma, and you may go down the wrong path. Because if you think it's a palisaded granuloma, then you think about GA, rheumatoid nodule, and NLD. So make sure that the palisaded nature that you're seeing is true palisaded or pseudo-palisaded. Pseudo-palisaded is classic for a suppurative granuloma because the necrosis it produces in the center will look like palisading. So that's why you have to go to the center of the granuloma where you're seeing the pink stuff. And this clearly is not a palisaded granuloma because this is, you see the nice suppuration, you see the neutrophils, so, and all the pink area is the necrosis. So this is when you deal with an infection. Now, when you are seeing a suppurative granuloma, you are thinking about an infectious process. Now, either you see the infection or you don't see the infection. So the most common causes of a suppurative granuloma are, say, Miyawki's granuloma, in which case you will see the fungus. Or suppurative granulomas are produced by deep fungal infections like leishmania or coccidio or blasto, which we will talk about when we are doing infection. So you either see the organism or you don't see the organisms. When you don't see the organism, that's when you think about mycobacterial and atypical mycobacterial infection. They are the most common causes of a suppurative granulomatous dermatitis, which is like invisible. In that scenario, in a normal workup of suppurative granulomatous dermatitis in any laboratory, when you're thinking that this could be infectious, you do a bunch of tissue stains. So we can do a gram stain to look for bacteria. We will do a PAS and a GMS stain to look for fungus. We will do acid, fast, and fight stains to look for mycobacterial organisms. Most important are the acid, fast, and fight stains. The acid, fast, and fight stains, you do them and we have to thoroughly examine it under high power to look for any organisms. If we get lucky, we will find the organism, which would be a mycobacterial or atypical mycobacterial infection, which will then need to be culture confirmed. If your stains are negative, you will tell the clinician to culture the lesion, which has to be a fresh tissue culture. And if the culture doesn't yield anything and you're still suspecting an infectious process, then you have to do PCR analysis on fresh tissue, which is not done in a lot of places. There are only a few laboratories in the country that will do that. But, that can be very, very useful. So this is a suppurative granuloma, and that's how you work it up. So now in your board purposes, when you're seeing a suppurative granuloma, again, you're either going to see the organism or you're not going to see it, right? So this is a classic example of a suppurative granuloma with caseation necrosis in the center. You can see that. So you can see how on low power, this will give you a palisaded look. So you may think, oh, this is GA, NLD rheumatoid nodule. So you will go down the wrong route if you're not paying attention. So you have to look at the composition of the granuloma. And now you see that there are nice neutrophils, there are histiocytes, and this is all pink caseation necrosis within the lesion. So this lesion will need to be cultured, will need to be stained up if you don't see the organism. So in your board, for your boards, you either see the organism or you don't. If you're not, then you're dealing with the mycobacterial, atypical mycobacterial infection. So M. tuberculosis, Burulli's ulcer, which is your Mycobacterium ulcerans, or swimming pool or fish tank granuloma, Mycobacterium marinum. Mycobacterium chelonia and fortuitum are the most common causes of atypical mycobacterial infection in the skin following wound contamination. Mycobacterium kansasi is typically in the lung and the lymph nodes, but can occur in the skin in immunocompromised individuals. And lastly, you have Mycobacterium avium infection, which largely, again, is in immunocompromised, especially the AIDS population, but can occur in immunocompromised individuals as well in the skin. So this is how the fight stain will look like. In this particular scenario, we got lucky because when we did the fight stain, we can see that there is a lot of bacteria in it. But this may always doesn't happen. This chain can be a little challenging because we have to look at multiple levels, but if we are paying attention, we often will be able to find the organisms for mycobacterial or atypical mycobacterial infection. Okay, so that was about your suppurative granuloma. Now let's talk about a specific kind of a disease which often produces granulomas, and that is rosacea. So rosacea can be a very non-specific diagnosis to an established diagnosis. So most often it is used as a diagnosis of exclusion. So when you're biopsying a rash on the face, you want to make sure it's not lupus. You want to make sure it's not sebderm or psoriasis or contact derm, and then you have rosacea. So either rosacea will show findings of not those diseases, and hence it's rosacea. You see the subtle findings like just telangiectasia, or it has well-defined findings. So because of that reason, rosacea often is not by itself, is not a classic board slide to be tested on. But this is a beautiful slide of rosacea, which actually shows you, all the well-formed features of rosacea. So very often, you will see almost always, you will see telangiectasia. So this is a biopsy from the face. And it's from the face because you're seeing all these pilosebaceous units and these villous hair follicles. You see that there is nice background telangiectasia. You can see the nice telangiectatic vessels. And again, you will see tuberculoid granulomas. Tuberculoid granulomas means there are lymphocytes and histiocytes in a perifollicular and perivascular distribution, most often surrounding the hair follicles. These are tuberculoid granulomas which will have a sprinkle of neutrophils in them. So you can see that they are neutrophils. You definitely see neutrophils in rosacea. You may not, but you most often see neutrophils in rosacea. So you can see that these neutrophils with lymphocytes and histiocytes forming a granuloma are present around this hair follicle. So these findings are classic for granulomatous rosacea. Demodex mites, when we find them in rosacea, we will report them because they can be treated with ivermectin. So you want to report Demodex mites if you see them in rosacea. There's a specific type of rosacea which definitely tends to be board tested, and that is lupus miliaris disseminatus fascia or acne aggminata. This variant of granulomatous rosacea presents with a monotonous monomorphic papular eruption, most commonly involving the central portion of your face. And again, on low power, when you look at the granuloma, it may look like a palisaded granuloma because of the central necrosis. So again, I'm saying this again and again, because when you are going to be reviewing slides for granulomas, that question is going to come to your mind. Is it a true palisaded or is it a pseudo-palisaded? And pseudo-palisaded is because of central necrosis. In lupus miliaris diffuse fascia, acne aggminata, you will see one giant granuloma with central necrosis. So this can look very much A, like a palisaded granuloma, and B, it can look like an infectious granuloma. What you have to recognize in lupus miliaris is, first of all, the classic appearance of it. There is one granuloma with central focus of necrosis, which is centered around a hair follicle. So you can see that it's kind of like vertically oriented. You may not see the hair follicle because the hair follicle may not be present in that section, but you have to imagine the hair follicle. It's a big granuloma with central necrosis. And it can look, when you go on high power, very infectious because it will have neutrophils and lymphocytes and histocytes, but that is fine. It's one giant granuloma in a folliculocentric distribution, and that's lupus miliaris erythematous fascia. The central necrosis is very prominent. So that will help you to recognize this particular entity. It's got nothing to do with lupus, as the name suggests. It's got nothing to do with tuberculosis, as the name suggests, because it has miliaris in it. And that's just because I think it is labeled like that because of the central caseation necrosis, which is one of the defining features of tuberculosis granuloma. So that is acne acuminata. So that's an important board question. Okay, now let's go on to your next category of granulomas, which are your palisaded granulomas. So palisaded granulomas are when something dies in the dermis and the inflammatory cells are collecting around it to get rid of it. That's in summary what a palisaded granuloma is. So this, you can see that there is a area of necrobiosis. There is a destroyed center portion of the dermis, and these inflammatory cells are collecting around it. So based upon what substance dies in the dermis or how does it look, a palisaded granuloma is classified as GA, NLD, or rheumatoid nodule broadly. So in GA, the central substance, which is altered collagen, is often accompanied by mucin. In necrobiosis lipoidica, the central collagen is very thick and sclerotic, so it's very morphia-like. And in rheumatoid nodule, it's fibrin, it's fibrinoid necrosis. So it has a kind of like, if you stare at it enough, it will give you an infectious look to it. So this is an example of GA where you get the palisaded granuloma with the central necrosis. And the location on aqueous skin is a good location for it. So let's see some more examples of GA. So again, this is a biopsy from the hand. The best diagnosis of GA is always made at low power. If you can recognize it at low power, that's your best bet. Because if you go on high power, it gets too much to decide. So when you are on low power, you will see the nice architecture of the lesion. So you can see that there is a granuloma here. There is another granuloma here. You can see this is a granuloma right here. This is a granuloma here. This is another. So randomly placed granulomas rather than organized granulomas, what you're going to see in necrobiosis lipoidica. There's a granuloma here, here, and here. Low power, you can see that this granuloma, we got the edge of it has mucin in it. You can confirm it with the mucin in here. This particular granuloma, this is another granuloma. This is the dead substance inside it. And you can see it's this altered collagen, necrobiotic swollen collagen. This is kind of like the interstitial variant of GA, where you're getting these lymphocytes and histocytes, which are like wrapping around individual swollen collagen bundles instead of having one discrete area of necrobiosis. So that's nice GA. The other thing about GA to notice it, if you are on low power, the lymphocytic infiltrate can be distracting. So sometimes GA presents with a superficial deep lymphocytic infiltrate, and if you're not paying attention, your eyes will not go to the palisaded area. It will just catch that lymphocytic infiltrate. And again, you can go down the wrong path of lymphocytic infiltrate. So this is another example of GA, and this is a really good example. You can see that there is busyness in the dermis here and here. And this is a beautiful example of GA where you can see this necrobiotic collagen. There is a little mucin in it, and these inflammatory cells are palisading around it. There is no other distracting feature in this slide, so this can be an easy one to recognize. Let's see some more examples of GA. This is another one. So like, for example, in this one, if you're not paying attention, you see a superficial and a deep lymphocytic infiltrate. So you can go down the wrong route when your eyes are supposed to be picking up these regions, not this region. This is a region where there is busyness in the dermis. When you go on high power, you can see that there is nice palisaded artifact, a palisaded granuloma with these cells collecting around this swollen necrobiotic collagen. So that's GA. There is one granuloma here. There is another granuloma here. So it's again randomly placed. What can even be more challenging is your interstitial variant of GA. So what happens in interstitial variant of GA is that there is an interstitial infiltrate of lymphocytes and histocytes, which is doesn't produce any discrete necrobiosis. You can see this busy area in the dermis, And you can see these lymphocytes and histiocytes, and they are wrapping around these swollen collagen bundles. Now, interstitial GA, clinically, you guys never pick it up to be GA. It always comes in as rule out CTCL, or never think about GA, honestly. And under the microscope, again, it produces a busy appearance with an interstitial infiltrate. Now, the two things which you need to be thinking about when you're looking at interstitial GA is that A, the cellularity fits for GA, and B, there is not significant atypia. So you have to go on high power to confirm that the cells that you are seeing are histiocytes and not any other things, because the two entities which can mimic interstitial GA, the pattern in the dermis, is metastatic breast cancer and leukemia cutis. So we need to make sure that we are not dealing with those entities. Now, for example, in this particular case, when you look at low power, this produces you the busy appearance in the dermis. And this is very easy to misinterpret as GA if you're not paying attention. But then when I go up on high power, I see that these cells are not histiocytes. What are these cells? You can see a cell with a nice intracytoplasmic vacuole. So these are all signature cells. And they're all lining up one after another in between the collagen bundles. So this is the indent filing. And you can see that these cells have beautiful signaturing morphology with intracytoplasmic vacuoles and eccentric nucleus. So this is an adenocarcinoma. This is an example of metastatic breast carcinoma to the skin, which is mimicking GA. So you have to go on low power to be able, on high power to be able to see the nature of those cells. The other thing would be leukemia cutis. So again, leukemia cutis will present with cellularity. So there is going to be it's going to be much more cellular. When you go up on high power, these cells are, you can see that they are much more hyperchromatic. They're not histiocytes. And unlike your breast cancer, where they were vacuoles, these cells have cytoplasm wrapping around them because they are monocytic in derivation, myelomonocytic in derivation, because the most common leukemia cutis that involves the skin is the M4 subtype. So this is leukemia cutis and not metastatic breast cancer and not GA. So you have to go on high power to look at the cells and to be making sure that you're dealing with GA and not a malignant process. Okay, next coming to the next palisaded granuloma, which would be necrobiosis lipoidica. So in NLD, you get palisaded granulomas, but they are very organized granulomas as compared to GA. They will involve the breadth and the depth of the biopsy from side to side and top to bottom, right up to the fat. And the granulomas, unlike GA, which was one granuloma here, another granuloma here, another here, these are very organized. So you can see that there is one layer of granuloma, another layer, then another layer, then another layer. And the cream of the cake is the sclerotic collagen. So this is the dense sclerotic collagen, which is very different from what the necrobiotic collagen in GA looks like. And plus, it doesn't have mucin. And also at the junction of the dermis and the subcutaneous tissue, you will often find plasma cells, as you can see in over here. So those are all good features for necrobiosis lipoidica. Now, what happens over a period of time that this granulomatous infiltrate can die off, like it will subside. But what will remain behind is obviously the sclerotic collagen. And if just the sclerotic collagen remains, and if you do a punch biopsy, it can have a very morphia-like feel to it. So you may think that you are dealing with morphia. So for example, in this old plaque of NLD, which is not an uncommonly biopsied scenario, you will see that there is a squared out effect. There's a punched out lesion with a squared out effect, which is what you see in morphia. You see the same sclerotic collagen, which is what you see in morphia, but this is the sclerotic collagen of NLD and not morphia. And the clue for that is presence of vague granuloma. So you can see these are histiocytes and giant cells in the background, suggesting that this is a resolving palisaded granulomatous dermatitis with sclerotic collagen. So this is an example of NLD and not morphia. They can be put in the same differential diagnosis, so you have to think and reason to yourself, in morphia, you will never get granulomas. So this is NLD and not morphia, even though it's producing you a squared out effect. Okay. Then last granuloma in palisadic category, which we're going to talk about, is rheumatoid nodule. So in rheumatoid nodule, you get these large geographic areas of necrosis. So you can see this large palisaded granuloma with this geographic area of necrosis. And the center, so it's one giant granuloma. You can see that here. you can see that the geographic area of necrosis that has these bluish areas. These bluish areas are because of the fibrinoid necrosis. So you can see the nice pink fibrinoid necrosis with a splatter of neutrophilic debris in the background, which gives it the blue basophilic appearance. So this is a beautiful example of a rheumatoid nodule. Again, the architecture of the lesion is very important. Also, rheumatoid nodules are most often in the deep dermis or the fat, but that doesn't mean that they cannot be situated superficially in the skin. You can absolutely have them in the superficial dermis as well. So do not use that as a criteria for recognizing is it a rheumatoid nodule or not. It's this nice geographic area of necrosis, the alternating blue and the pink morphology. You can see it has kind of like the necrotic area, instead of being pink, it has this kind of a bluish tinge to it because of the fibrinoid necrosis. So that is rheumatoid nodule. So the inflammatory granulomas we have talked about are your sarcoidal granulomas. We have talked about because of sarcoidosis or foreign body and tattoo pigment. We have talked about your tuberculoid granulomas in leprosy and in syphilis. We have talked about suppurated granulomas correlating to infection. We have talked about granulomatous rosacea, including lupus miliaris dysgeunatus fascia. And then we have talked about palisaded granulomas, which is GA, NLD, and rheumatoid nodule. So that was about your granulomatous inflammatory diseases. Now, let's move ahead to your granulomatous neoplasms. So when we are going to be talking about granulomatous neoplasms, the way you're going to broadly classify it is it Langerhans cell driven or not Langerhans cell driven? If it's Langerhans cell driven, that means you're in the Langerhans cell histiocytosis category. And if it's not Langerhans cell driven, then it could be a xanthogranuloma, a reticular histiocytoma, and Rosai-Dorfman disease. So those are the broad categories that you think about. Now, we know that Langerhans cell histiocytosis is derived from the Langerhans cells, which are going to be antigen-presenting cells, so they live in the epidermis. So that is why Langerhans cell histiocytosis, instead of looking like most often like a tumor, it presents as a rash. So you will see erosion and crust, and when you're looking at the biopsy of those lesions, you may not think that it is a neoplastic process. You may think it's eroded, crusted. Is it eczema? Is it sebderm? It's psoriasis. But you can see that there is infiltration of the epidermis by these cells, which do not look like any normal cells that you have seen. Many of these cells have these bites in them, so they produce these nuclear grooves and inclusions with these indentations, which look like clover bean or kidney bean shaped structures. You can see that, and this is a nice groove within the lesion. It looks like a nice kidney bean, many of these cells. Eosinophils are a part and parcel of these lesions. So you can often always see eosinophils in the background. These are all Langerhans cells, which will stain with CD1A and S100, and also with Langerin, but we do not really need to do Langerin. If you just do a CD1A and S100, that's good enough. And also on electron microscopy, which we do not need to do, but it's a board question that is asked, you know that they show the tennis racket-shaped Bilberg granules. So Langerhans cell histiocytosis could either be Langerhans cell histiocytosis, it could be a self-limiting version of it called Hashimoto-Pritzker disease. It could be in a more systemic form like Hanschel-Christian and letter C disease, but the histology all looks the same. And that is proliferation of these Langerhans cell histiocytes, which are the cells which will have bites with clover bean or kidney bean shaped morphology and these grooves and inclusions. And they are CD1A and S100 positive. So that's Langerhans cell histiocytosis. If it's not Langerhans cell mediated, then what else could it be? So we are going to talk about xanthogranuloma and reticular histiocytic granuloma. So xanthogranuloma can occur in any age, more common in younger individuals, hence the name juvenile xanthogranuloma, but it can typically occur in any age. They are big lesions, papillonodular lesions, often kind of like effacing the dermal architecture. It's kind of well circumscribed, but not encapsulative, and it can go into the deep dermis as well. And what you see in here on low power, it can look pretty confusing and it can look challenging. When you go up on high power, you will see proliferation of these cells, which will look ugly, but they are fibrohistiocytic cells. They are very pleomorphic, but they're all with a bland morphology. They're not that ugly. And then when you see the two-tone giant cells within the lesion, that will clinch the diagnosis. But remember, the two-tone giant cells within the lesion may not always be present, especially when it's in its proliferative stages or inflammatory stage. You will see background inflammation with every cell. You can see lymphocytes, eosinophils, neutrophils, that's all accepted. But obviously, when you see the two-tone giant cell, you know for sure that you're dealing with this. A two-tone giant cell has a ring of nucleus with the pink cytoplasm in the center and foamy cytoplasm outside it. So this is a great example of a xanthogranuloma, and you're seeing numerous two-tone giant cells in the lesion. You can see the nice ring of nucleus with the pink cytoplasm in the center and the foamy cytoplasm outside. So that's a two-tone giant cell. Now, a xanthogranuloma could be completely incidental, like a solitary lesion, but can also occur as a part of systemic diseases. So you can have patients who have multiple of these xanthogranulomas and like benign cephalic histiocytosis, generalized eruptive histiocytoma. It could be an ALK1-related entity, which is now being more described in patients who have multiple xanthogranulomas and internal organ involvement. You can do an ALK1 stain, and there is a subset of it which are ALK1 mutation related. ALK1 fusion related. So, you should know about that. They can show you this question and they may not have, they can show you this slide and they do not have classic xanthogranuloma, and they have one of those histiocytic disorders like spindle cell xanthogranuloma, scallop xanthogranuloma, benign cephalic histiocytosis, generalized eruptive histiocytoma, or xanthoma disseminatum. Xanthoma disseminatum is a favorite board question because it has the word xanthoma in it, but it has got nothing to do with a lipid disease. The histology looks like a xanthogranuloma, and these patients have an underlying monoclonal gammopathy or a paraproteinemia, most common of the IgG type. And they present with hoarseness of voice because of laryngeal involvement, CNS involvement resulting in epilepsy or skeletal lesions, as well as diabetes insipidus. So remember, xanthoma disseminatum, the histology of it will look like a xanthogranuloma. What about a reticular histiocytoma or a reticular histiocytic granuloma? Again, reticular histiocytoma, they can occur as solitary lesions, and they can also be seen in patients with multicentric reticular histiocytosis. So in multicentric reticular histiocytosis, patients have multiple reticular histiocytic granulomas, and they also have paraneoplastic manifestations such as carcinomas of the lung, bladder, or the breast. But most importantly, they have arthritis, a progressive destructive arthropathy. They can have endocrine abnormalities like diabetes or thyroiditis as well. But the histology of the reticular histiocytic granuloma is similar to what you would see in one single lesion. And that is here, you again have fibrohistiocytic cells. So the background fibrohistiocytic cells are very similar to a xanthogranuloma, but instead of having the two-tone giant cells, you have cells which are large, which have abundant amounts of this kind of dense granular pink and amphiphilic cytoplasm. So you can see this kind of a ground glass cytoplasm, which has also like a bluish tinge to it. So it's amphiphilic in nature. So this is PAS positive, and it apparently also has lipid. So it can also be Sudan black positive. So you can see this reticular histiocytic cells with this kind of dense ground glass or bluish pink cytoplasm. So that's a reticular histiocytoma or a reticular histiocytic granuloma. Lastly, in this category, we are going to talk about Rosai-Dorfman disease. So what happens in Rosai-Dorfman disease? In Rosai-Dorfman disease, it's a benign histiocytic disorder in which patients present with the classic finding of imperipoiesis, which is non-destructive phagocytosis of inflammatory cells by histiocytes. Now, Rosai-Dorfman disease can occur in a systemic variant form, which is known as sinus histiocytosis with massive lymphadenopathy, which has a different demographics. That more commonly occurs in younger males. They can be either Caucasian or African American, but they present with fever, night sweats, weight loss. So there is a systemic component to it along with lymphadenopathy. So the Rosai-Dorfman disease in that case is involving the lymph nodes. However, in the cutaneous variant, patients present with just cutaneous lesions and no other systemic involvement. And that cutaneous variant of Rosai-Dorfman disease has a different demographic. So it occurs more commonly in middle-aged or elderly females, Caucasians, or Asians. And clinically, I have seen varied presentations of Rosai-Dorfman disease in the skin. The most common presentation is nodular lesion, which kind of clinically mimics keloid or DFSP. But you can have varying presentation. You can have an acne, resistant acneiform eruption. You can have a lesion that looks like granuloma facial or vasculitis or acne rosacea. Or it can have bizarre, absolutely bizarre clinical presentations I have seen where you would not really think about cutaneous roside-Hoffmann disease. The histology is pretty similar. So when you biopsy a lesion of cutaneous roside-Hoffmann disease, what you see on low power is zonation. So you can see that there are these blue areas and pink areas. So there are blue areas and pink areas. Now, what are the pink areas? So the pink areas is the one that will make the diagnosis. You'll go up on higher on pink areas. And what you have to see, the pink areas are actually these syncytial aggregates of epithelioid large histiocytes. So you can see that they are large histiocytic cells, and in the background is this bunch of other cells. So how do you recognize it? So the way I want to teach you guys is that you look at the nucleus. So, tune out the background noise, which is the cytoplasm, because that's difficult. Just look at the nucleus. So you will have two types of nuclei, but different types of, two colors of nuclei, but different types of nuclei. The two colors will be the darker one and the lighter one. The lighter are the histiocytic nuclei, and these will also tend to be bigger in size. That's a histiocytic nucleus. That's a histiocytic nucleus. That's a histiocytic nucleus. So they are lighter. And their cytoplasm is around them and is all joining together to form this kind of pale pink vacuolated background. And inside the cytoplasm will be the darker nuclei. The darker nuclei can be of lymphocytes. So like as you can see in here, this is of a lymphocyte. It can be of a neutrophil or an eosinophil, as you see in over here. It can be of a plasma cells. Plasma cells are an important component of the lesion. So often at the edge of these pink areas, you will see collection of plasma cells. That's a very important part of roside-Hoffmann disease. So this is how you recognize it. You see the nucleus, see the lighter and the darker nucleus. The lighter is the histiocytic nucleus, which tends to be also bigger. And the darker will be the other inflammatory cells. So they can be neutrophils, lymphocytes, red blood cells. They can be eosinophils, neutrophils, all present in the cytoplasm of these histiocytic cells. So that's non-destructive phagocytosis by the histiocytes, which is emperipoiesis. And these histiocytes, so these pink areas, will all be S100 positive. So in roside-Hoffmann, they're S100 positive, but they're CD1A negative. And that's how you distinguish it. Obviously, the histology is very different, but from Langerhans cell histiocytosis. So that's roside-Hoffmann disease. So that's an important board question as well. They like to test you on that. Next thing, I just want to quickly mention about atypical fibroxanthoma. We'll talk about it more when we are covering our slides. But in atypical fibroxanthoma, the reason I try to include this in here is because it can present with very ugly giant cells. It's a malignant spindle cell neoplasm, which is fibrohistiocytic in derivation, and it is a diagnosis of exclusion. So when you're diagnosing it, you want to make sure it's not a bad melanoma or a squamous cell or a leiomyosarcoma or an angiosarcoma. But the look of it, and at first you may disagree with me, but when I throw in questions in a mix towards you guys, then it can be confusing because AFXs often have giant cells. And because of the presence of giant cells, you may think that it is a benign entity, but it's not. Those will be very bad looking, ugly giant cells, and this tumor is notoriously very ugly looking. So you can see that there are going to be background mitosis, there is atypia, there is pleomorphism, and even the giant cells won't look that good. So that's how you'll know that you're dealing with an atypical fibroxanthoma. So that's an important board question. We'll talk about more of the staining pattern when I'm reviewing your study sets. The next one we're going to talk about is xanthomas. So what are xanthomas? So xanthomas are going to be entities where you will see a collection of foamy histiocytes. So foamy histiocytes or xanthoma cells are the histiocytes which contain lipids. So they have a foamy vacuolated cytoplasm. So xanthomas always have one kind of cell, and the one kind of cell is a lipid-containing cell, okay? But the lipid may be present in varying stages of maturation. So you may have a histiocyte which has beautiful entire lipid in it and looks very foamy and vacuolated. Or you will have a histiocyte which doesn't have a lot of lipid in it. It's in its early stages, so it looks more pink. They're all one kind of cells, but they have lipids in varying stages. So that can what make the diagnosis challenging. They will be associated with an underlying lipid disorder. hyperlipidemia. So you need to know those associations. Xanthelasma is a commonly asked board question. In xanthelasma, you get a very thin epidermis with numerous villous hair follicles, and you guys never have a problem recognizing it because you will see these nice nodular aggregates of histiocytes with the foamy cytoplasm present in the dermis around the hair follicles around the vessel. So no problem in diagnosing. You can see there's a nice, beautiful aggregate of these xanthomatized histiocytes. So that is xanthelasma. The one that can be a little challenging is an eruptive xanthoma. So what happens in an eruptive xanthoma is this is associated with hypertriglyceridemia. So when the patient's triglyceride levels go up, they're going to pop this eruption, which is eruptive xanthoma. Because it's in acute stages, at low power, it produces you a busyness in the dermis. So it can look like GA. But when you go up on high power, you will see that these are actually one kind of cells. These are the xanthomatized histiocytes, so they can contain big bubbly cytoplasm, and it's in varying stages. So that is why some of them look more pink, some of them look more vacuolated. Extracellular cholesterol clefts can be seen within the lesion as well. They're not present in this lesion, but they can be present. The most easiest one to recognize are your tuberous and tendinous xanthomas. So tuberous and tendinous xanthomas will have sheets, nodular aggregates of histiocytes, all of which will contain lipid. And the background has these beautiful cholesterol clefts. So you can see these slit-like spaces which have these lipid deposits, these kind of like flaky substance in them, which is your lipid, extracellular lipid. And you can also have two-tone giant cells within the lesion, because what are two-tone giant cells? They are again xanthomatized multinucleated histiocytes. So that is your tuberous or tendinous xanthoma. Verruciform xanthoma is a type of a xanthoma which has got nothing to do with the generalized lipid disorder. These patients present with lesions, say, like in the oral cavity or intertriginous sites. And what you get is like a wart-like proliferation. And another clue for verruciform xanthoma is these broad columns of parakeratosis. They almost look like huge flame fingers. And or cornoid lamellae is what I get. These are not cornoid lamellae. They're just broad columns of parakeratosis, but they are always present in every verruciform xanthoma. And within the expanded dermal papillae of these fingers, you will see these papillary fingers, you will see there are xanthomatized histiocytes, so foamy histiocytes. Now, this verruciform xanthoma has got nothing to do with the lipid disorder. This is a localized problem wherein the epidermal keratinocytes, they get destroyed, they release the lipid, and the lipid is phagocytosed by the histiocytes. So it's got nothing to do with a generalized lipid abnormality. Some of the conditions that can be associated with verruciform xanthoma is like lupus or epidermolysis bullosa, anything which will destroy the epidermis. However, most of the time they occur in idiopathic form, so we don't know the cause of it. So that is your verruciform xanthoma. Lastly, I'm going to talk about some of mimicus of granulomatous diseases. So first of all, so like entities which will have either giant cells like AFX, or they will have two-tone giant cells or xanthomatized histiocyte, which will make it look like a lipid disorder, or mimic a granulomatous process. So dermatofibroma is a classic example. Granular cell tumor is another example. So let's first talk about a granular cell tumor. Granular cell tumor on low power, because of the pale cells, can look like a xanthoma. But when you go up on high power, you will see that the granular cell tumor has actually nested cells which have pink eosinophilic granular cytoplasm. And these are all Schwannian in derivation. So they are derived from S100 positive Schwannian cells. And these granules are all lysozymes. And you see these nice perinuclear pink inclusions, which you're seeing in here, which are pustulo-ovoid bodies of Millian. So granular cell tumor is a classic mimicker of a xanthomatous process. Another one would be a hibernoma.
Sorry,
so hibernoma.
Pustular bodies. Can you just repeat that?
Yes. So let's go back to your granular cell tumor, which was here. So granular cell tumor, pustulo-ovoid bodies of Millian are the pink perinuclear inclusion. So if you see these are the big cells, right? They have the granules. You see that? You see the granules?
Yes, got it.
And then you see that next to the nucleus, there is this big pink inclusion, which has a halo around it.
Yeah.
There's another one right here. See that?
Great. Yep. Thank you.
That's your pustulo-ovoid body of Millie. And do not confuse this with the Michaelis-Guttman bodies, which also look targetoid like this. That is a buzzword for malakoplakia. Okay? Malakoplakia also has, I didn't want to mention that over here, but malakoplakia will also have granularity to the cells, but that granularity is produced by bacteria. So that's a different entity. So this is pustulo-ovoid bodies of Millian granular cell tumor. You can see that. The granular cell tumor can be the overlying epidermis can be hyperplastic, can be normal, but the cytology of the cells is pretty classic for that entity. Hibernoma is another mimicker because hibernoma will produce you this kind of this vacuolated appearance. So this is not a hibernoma, I'm sorry. Yeah, this is a hibernoma. So you can see that it's a tumor of the brown fat where you see the cells which are mulberry cells or the spider cells. Once you see it, you will always remember that this is a hibernoma, but it can mimic silicone granuloma, right? Which has a Swiss cheese appearance, which I'm going to show you very soon. So this is a hibernoma, which is a tumor of the brown fat. In contrast to your silicone granuloma, which is a foreign body reaction. The other types of silicone granulomas are referred to as paraphenomas or sclerosing lipogranulomas because they produce these holes in spaces, which looks A, like fat, and B, like a hibernoma, right? But this is not true fat. This is produced by substance which has been washed away and producing these fat-like droplets. So the way you will recognize this is a foreign body is because there is marked variability in the sizes of these droplets. And there is associated giant cell reaction with it. So there is a granulomatous reaction with it. So this is known as a Swiss cheese appearance of a silicone granuloma. And this is how even a paraphenoma or sclerosing lipogranuloma will look like. So this is an example of a silicone granuloma, which can mimic a hibernoma. So we need to know that. Another mimicker of a granulomatous process, which you guys should know, is lepromatous leprosy. So unlike tuberculoid leprosy, which we talked about earlier, which produces tuberculoid granulomas where you can barely see the organism, in lepromatous leprosy, you will see a nice Gren zone. So Gren zone, and the body's immunity is that bad that it doesn't form any granulomas. It produces your sheets of histiocytes, and these histiocytes have clumped bacteria in them, which are called globoid cells. So you can see these organisms, which are, you don't even need to do a stain. You can nicely see the organisms. You can see here a cluster of organisms inside these histiocytic cells. So that is lepromatous leprosy. So a sheet of histiocytes with bacteria within them, and those intracellular bacteria, the histiocytes containing the intracellular bacteria, are referred to as the globoid cells. So
can you point out some more of those globoid cells, or like
yes.
the specifically the bacteria?
So this is another biopsy. So you can see that everything here, we can see that there are these holes in spaces. And you see them now? This is one globoid cell. This is another one. See the fluffy bacteria?
Like, I don't know if it's just me, but it almost looks like a defragmented nucleus. So I wouldn't feel
It's
like
too big for a nucleus. So at this power, this is a nucleus.
But like, for example, the two that are on the screen right now, right in between it is a histiocyte with a nucleus that's just as big.
Yes, I agree. It's probably not a histiocyte. It's a fibroblastic cell with a reactive nucleus. But if you look at the morphology of this is entirely intact. And this is a clump. It looks like a cotton ball, like it looks fluffy. Let's see more examples. Like here, it almost looks like it has a granularity to it, but it is all clumped up.
Like it almost looks like a mitotic cell to me. Like I can see it better on high power, but at low power, like I would think those are mitoses.
Mitoses look very different. Mitoses have very well-defined filaments. This is like a clump of, you need to Google it. Google it and you will see the mitoses will look very different. These are all clumped up bacteria, and I'm at a very high power. It's 52 right here. So we normally do not have that luxury. Can only probably go up to a 40, which is probably a better power to stay at because you can appreciate the granularity actually better at this power.
Yeah, I can definitely see it at this power, but I think it's like my eyes deceiving me at lower power. Like when you zoom out probably to 20x or like
This will be at 20x.
maybe 40x.
Yeah, I think 40x is a good place to recognize it, but it is, it looks, Google some of how a mitotic figure looks like. A mitotic figure will look very different. Like it has very well-defined structure to it. This is more like, it really reminds me of like the cotton balls inside the empty cells. And it's always going to be present in a space, and that space is actually a histiocyte, because the histiocytes are phagocytosing it and producing it inside them.
Got it.
Okay, whereas a mitotic figure will not have that space around it.
Got it. Thank you.
So that is your lepromatous leprosy. And then what else? And a dermatofibroma. Dermatofibroma, you guys have no problem recognizing it. That can mimic a xanthogranuloma, because a dermatofibroma can also, it's also fibrohistiocytic, but it has a nice collagen trapping at the periphery. It has the induction. It often has areas of hemorrhage. Whenever it has a two-tone giant cells and xanthomatized histiocytes, it often has hemorrhage with it. So all those features will be lacking in a corresponding granulomatous neoplasm like xanthogranuloma. So that's how you would recognize it. So with that, I'm going to end. I have sent you guys 2 study sets, which is granulomatous 1 and granulomatous 2. They're not easy. Some of you may have done granulomatous 1 before, but I don't think so anybody has done granulomatous 2. And they are very, very important study sets, because I think if you pay attention to what all I taught you today and actually take the time to go through them, you will understand granulomatous diseases very well. So I think I'm going to spend the next class doing that, but it would be really, really productive and useful if you guys look at it before, and we can have a discussion, because I want to know what you guys are seeing so that I can point out to you and that go about this way. So remember the certain concepts we talked about today. What is palisaded? What is pseudo-palisaded? What are the mimickers of granulomatous entity? What is a sarcoidal granuloma versus a tuberculoid granuloma? All those concepts are important. You will have the recorded version of this class. If you want to go back and listen to it, it's nice, because it's a lot of stuff covered in 1 hour, but I think it's very high yield. So we will do those in the next class.